Well, good morning, everyone. Hopefully, though, there you go. That's what I was looking for. Good morning, everyone. It's wonderful being here in Dubai. It's such a lovely time of year here, and I really appreciate the opportunity to be at this wonderful meeting. The UAE Society has already established in a very short period of time its reputation for excellence around the world. And again, I'm very thrilled and honored to be here at this important conference. So let's see here. If we can get the clicker to start working. All right, so first of all, I have worked for the American Heart Association for 3 years and left in last February, but no other conflicts. And today what we're going to do is talk a little bit about acute congestive heart failure management, particularly the challenges around evidence-based management of congestive heart failure and some of what the best practices may be that really go beyond the guidelines. And I'm going to have to go relatively fast because we only have 20 minutes, and I'm going to try to adhere to that. Now, there are estimated to be 23 million people around the world with congestive heart failure, and while we don't have great statistics on most of the world beyond that, we know that the annual death rate approaches 20%, and that in the U.S., most patients are admitted through the emergency department, which should be true in most countries with advanced emergency care systems, such as here in the Middle East. We know also that in the emergency department, while acute congestive heart failure may be due to various things, that ultimately the pathophysiological concern that we have as emergency physicians is pulmonary edema. And pulmonary edema is really what we are most focused on treating in most CHF patients that we see in the emergency department. Now, there's a little bit of a joke about that being a veterinarian for horses is very easy because the treatment is always the same. No matter what's wrong with the horse, you shoot it. Of course, that's not really true, but it's sort of a joke about veterinary medicine for horses. And so I'd ask you the question, are diuretics such as furosemide, are those really our equivalent of shoot in the management of acute congestive heart failure in the emergency department? Because we know that the diuretics are our go-to drugs in acute congestive heart failure. And what I'd like you to think about by the conclusion of this talk, when you see your next CHF patient, is not whether or not you should use diuretics, but when you should use them and how intelligently you should use them, thinking about the specific phenotype of the patient that's in front of you. Now, the reason for that is really looking at the total volume of body water and body fluid versus what's in the lungs. Really, when we think of CHF patients being volume up, in acute congestive heart failure, they're not necessarily volume up. What's up is the volume in their lungs, not necessarily their total body water. And in fact, you can have euvolemia or even be volume down from a total body water standpoint and still have pulmonary edema in the lungs. And I think sometimes as clinicians, we forget this. So in the emergency department, again, very focused on the emergency medicine aspect of acute congestive heart failure, our goal is not really to empty the body of water, especially if if the patient's truly not volume up. We're trying to get water out of the lungs. We're trying to get fluid out of the lungs. And we can do that in 3 ways that we all know: decrease preload, decrease afterload, or improve LV function. Now, to reinforce this, some facts to remember. Remember that actually more than 50% of patients that you'll see with pulmonary edema in the emergency department are actually euvolemic or even total body volume water down. Okay? So it's not a problem of total body water being up, it's a problem of pulmonary edema, so lung fluid being up. Also, while we think of congestive heart failure as being a condition where people's pumps are not working, actually almost 50% of patients have preserved ejection fraction. And as a result of that, actually most patients with CHF will have an elevated blood pressure rather than be in cardiogenic shock. Less than 5% of patients with acute CHF in the emergency department are in cardiogenic shock. So what we as emergency physicians, let's not worry about what the internist or the cardiologist needs to do. What we as emergency physicians need to do acutely is not remove water, we need to redistribute fluid. That's what we need to do. We need to get it out of the lungs and somewhere else. And somewhere else may just be, just part of the vasculature or total body water. So, what should our approach to acute congestive heart failure in the emergency department be? This is a algorithm or a sequence out of Vanderbilt that's been suggested, and it essentially is something that really, while we have to list things, 1, 2, 3, 4, 5, is a list that really needs to be done simultaneously, as we all in the emergency department are expert at doing. And let's go through those. So the first thing is that we treat immediate life threats, and this should be obvious to any trained emergency physician. It's not the CHF that we need to deal with if someone is in VTAC, if someone has a STEMI. We need to treat those conditions, right? So once we've dealt with the immediate life threats, now we have to figure out the diagnosis. And we all know that this is not necessarily as easy as it sounds, because patients don't come into the emergency department with CHF stamped on their head. They normally come in dyspneic. More than 80% of them will come in short of breath, and they will have a variety of other historical and physical exam findings. It is very rare that you are going to get a patient in your emergency department who is the Netter drawing of congestive heart failure. They are going to have atypical findings. And so as clinicians, we use our cumin, we use the full spectrum of our physical exam findings to try to decipher whether this is congestive heart failure. Now, of course, we also know what's the biggest problem mimic that we have of, is it congestive heart failure, or is it, anyone? Somebody has a faint wheeze or something and they're short of breath. COPD, right, COPD. So that's the really trouble combination of diagnoses, particularly in a patient who has both, which is very common, as we all know. This is where cardiac echo or ultrasound in the emergency department can help to look at LV function. Now, also, biomarkers. If a patient has a positive troponin, we know that it's going to be more likely to be CHF type, maybe might just be elevated, maybe a type 2 MI. That's not something we're going to figure out for sure in the emergency department, but it points us in the direction that there is a congestive component. We know that if the patient has elevated renal function, that it's more likely to be CHF. And then we also have a test, BNP, that we can use to determine whether a patient has CHF or not. So what do we know about BNP from an evidence standpoint? What we know about it is that it gives us a spectrum of values, and depending on the values at your institution for your assay, there will be a high range, there will be a low range. We know that if a number is in the high range, that it will have up to 90% sensitivity, and the specificity will be lower, maybe 90% sensitivity, 75% specificity. If you raise your level of your cut point at what level you determine the test is positive, you can increase your specificity, but you will lower your sensitivity. So this is a classic test, not unlike a strep test or most other tests that we use. Troponin being the exception. Troponin's 100% positive at 12 hours, but still not complete specificity. But this is a test that when you increase sensitivity, you lose specificity, just like most tests that we have in medicine. However, based on the evidence, level B, evidence that a single troponin can assist clinical decision-making in determining whether a patient has congestive heart failure compared to clinical judgment alone. So how do most experienced clinicians use this? Well, again, not to insult any of my cardiology colleagues or anyone else, but from my perspective and from a lot of perspectives of experienced clinicians, we approach this very similar to how many of us approach strep testing. If it's obviously strep, we don't test, we treat. If it's obviously not strep, we don't treat. And if it's in between, then we do the strep test. Well, because a strep test has similar sensitivity and specificity to a BNP. So if it's obviously CHF, then you don't need a BNP. If it's obviously not CHF, you don't need a BNP. If it's in between, then use it to supplement your judgment. And that really is probably the expert consensus in the United States, at least, on how to use the BNP test rather than ordering it on every time. Now, when you get into determining treatment, treatment is determined and broken down by the overall clinical phenotype of the patient, including how severe their condition is, what the cause was, if we know what their ejection fraction was, what their heart rhythm is will affect the treatment. But we now have recently begun to break down, using the Braunwald six-axis criteria, break down CHF treatment by systolic blood pressure as well. So before we get to systolic blood pressure, what about the patient who's hypoxic or in severe respiratory distress from their pulmonary edema? Well, the first step is, before pharmacologic management, is clearly non-invasive ventilation. And if you look at the studies on CPAP and BiPAP in congestive heart failure pulmonary ventilation, they consistently improve mortality, they decrease intubation, and they improve every cardiac metric that you can think of and every symptomatic metric that you can think of with regard to the acute congestive heart failure patient. So for the patient who is dyspneic or hypoxic enough to tolerate CPAP or BiPAP, that it should be used essentially every time. Your biggest problem with CPAP or BiPAP is the patient will improve enough to the point where it's uncomfortable and they don't want it anymore. But that's a good prognostic sign, and that's a good problem to have. And again, the level of evidence for CPAP and BiPAP, which are therapeutically equivalent based on the literature, is a level B recommendation. Now, I said that we were going to stratify our pharmacologic treatment by systolic blood pressure. So most patients, as I said before, will come in with systolic blood pressures of 140 or higher. So let's go ahead and talk about them first. So the cornerstone in the first treatment for the patient with a systolic blood pressure greater than 140 should be nitroglycerin, and it should be intravenous nitroglycerin. Now, this can be a challenge sometimes in hospitals where nursing policies may be adverse to giving IV nitroglycerin for whatever reason. But IV nitroglycerin has by far the best evidence for any therapy in pharmacologic therapy in acute congestive heart failure. It reduces preload and afterload, and it should be given first with a load, and you can either load it IV or you can give I usually give the 3 sublingual nitroglycerin and then start the drip. But it's overall the best studied, the best evidence treatment for CHF. Not diuretics, nitroglycerin. If you need to reduce afterload acutely for some reason to a greater extent than nitroglycerin does, particularly in acute mitral regurgitation, if you have a patient with MR, then use nitroprusside. We all know nitroprusside can be quite inconvenient to give, but it is an option if nitroglycerin alone is not doing it. What about ACE inhibitors, channel blockers? They are also used. There are some people, and I'll talk about ACE inhibitors a little bit more in a second. There are a few people who actually argue against ACE inhibitors, but there are a lot of fans, and I think most emergency physician experts who have an expertise in cardiovascular emergencies, including Amal Mattu, who I can tell you that we give very similar talks on this because we've given them in front of each other before, will say that ACE inhibitors are a good plan. Calcium channel blockers, probably not so much, but you can use them. Diuretics, yes, you need to use diuretics, but we'll talk about how. And remember, your dose should be essentially usually 20 milligrams in the diuretic naive and 2 times the oral dose if the patient is not. Now again, the best study on acute congestive heart failure treatment was the VA study that looked at IV nitroglycerin versus IV furosemide, and it showed that in every way, mortality, symptoms, everything, nitroglycerin was superior to Lasix. ACE inhibitors have a renal protective impact that is very important, and this is something that, again, many experts will give because what we see is that the problem with diuretics is, number one, there is zero evidence that diuretics are effective in acute congestive heart failure. Zero. In fact, there's some evidence that shows that it might trend toward increased mortality. Why is that? Do I believe that diuretics are inherently bad in CHF? No, I don't believe that. The reason why that is because a certain percentage of patients will get kidney failure, and when you get kidney failure, you have a worse outcome. So if you can do something to prevent the patients from getting kidney failure, then you should see a benefit from diuretics. That's the rationale for giving ACE inhibitors. Increase renal perfusion, increase renal blood flow with ACE inhibitors, nitroglycerin, and then give the Lasix. So again, diuretics by themselves, no benefit, trends toward worsening because of kidney failure. So you need to be really careful about giving diuretic CHF and CHF. And again, the only recommendation evidence-based for giving diuretics is in combination with nitrites. So what many of us do we will give nitrites and ACE inhibitors initially and then give the diuretics 20 to 45 minutes later after the other drugs have had time to take effect. And this is supported by on a theoretical basis by the renal protection of ACE inhibitors versus placebo. And I'm really having to sail here. Morphine, give morphine if the patient has pain. Otherwise, morphine has increased mortality. It should not be used for preload reduction. Patients in between 100 and 140, really same treatment essentially as the patient greater than 140, except for the fact that you should be more cautious with your use of the IV nitroglycerin.
2 minutes.
Okay, cardiogenic shock. Cardiogenic shock, digoxin is good, especially with beta blockers, and use dobutamine, use dopamine if necessary. But again, try to reserve your diuretic use until you have the blood pressure sustained, and also make sure that you have good renal perfusion. Naseritide has been disproven as a therapy, so please don't use that. And when all else fails, you can go to the inner aortic balloon pump. Tachycardia, digoxin really is probably still the treatment of choice. That's the least dangerous in CHF, but you can use calcium channel blockers and beta blockers very cautiously if you use very low doses. Don't forget to manage the precipitant causes of CHF, and then disposition. Inpatient risk scores can be helpful to make a disposition. There are no clear scores on who to send home versus who to admit versus who to observe. A lot of this is based on institutional policy, who gets admitted to ICU based on hemodynamic instability primarily. So again, remember that acute congestive heart failure in the emergency department is a problem of fluid distribution, not fluid excess, and that you need to redistribute fluid in these patients. Make sure you use the tools at your disposal, BNP ultrasound in complicated patients. Use CPAP and BiPAP liberally in any patient that will tolerate it, and use diuretics intelligently. Do not just reflexively give diuretics. Wait and make sure the kidneys are getting enough perfusion before you give diuretics. So I thank you very much for your attention.